thank you very much for the invitation to come to this university. I've seen your university completely, and it's an absolutely beautiful campus. It's lovely to see many young faces. I hope I can teach some new and interesting ideas today. I've been given a nice broad topic, and I'll take you through what I think is a rather fascinating and evolving area in chronic cough. This is an area that hasn't really evolved a lot, but in the last 10 to 15 years there's been some very exciting developments, and I'll talk about some of these. It was working, but it's not working. All right, I'll use this. So, oh, did I turn it? Maybe I turned it off. That's okay. So just briefly, as the title stated, I will talk about cough guidelines briefly. There is, of course, an introduction to the Thai cough guidelines later, but I'll talk about probably the most important ones to date, at least from the European Respiratory Society briefly. I'm going to talk about some new approaches using possibly some old objective measures that might play a role in helping us understand different cough phenotypes and predict response to therapy. And I'll also talk about emerging treatments that show some very promising opportunities. However, whether we see these drugs soon will remain to be seen, but I'll talk about some of those studies and what they have taught us. So cough, of course, is a very important defense mechanism. And of course it prevents, the deposition of noxious stimuli and clears harmful debris. So we need our cough reflex. And I guess just to on that point, it's also important to understand that if we were to give a drug to block cough, we can't have a drug that works too well that completely blocks the cough reflex. We need our protective reflex. And so, of course, if we have impaired and insufficient cough reflexes, we increase the risk of infection. And of course, cough can be associated with underlying disease processes. And it's also interesting to know that it's the only defensive reflex that we can mimic voluntarily. So, who has chronic cough? Well, it's quite common. It's one of the most common presenting symptoms in medicine. It affects about 4 to 10% of the general population, and of course it's associated with other respiratory conditions, with smoking, with low socioeconomic status, and of course occupational exposures. And so 5% of this population, 5% of this population have treatment, have what we call refractory chronic cough or unexplained chronic cough. And this is likely associated with some underlying conditions. And I guess one of the really emerging advantages, understandings that we've had is really sort of the origins of what refractory chronic cough means in terms of neural modulation, in terms of driving cough that I'll discuss. So as I mentioned, it's a vital protective reflex preventing aspiration and airway clearance. And it's an important thing to note that chronic cough is more common in women, and one of the reasons for that is because of the protective reflex, particularly during pregnancy, the increased risk of reflux and aspiration. And this is one of the reasons that it's thought that the cough centre in the brain is larger and more sensitive in women than it is in men. Important thing to recognise, of course, is that when you have chronic cough, it can significantly decrease quality of life, incontinence, cough syncope. It's interesting, in lung function laboratories more recently I see patients who present with cough syncope, and spirometry is a lovely test to mimic cough syncope. You just have to make sure the patient doesn't fall out of their chair. But of course this can have significant impacts on a patient's quality of life. So chronic cough is defined as 8 weeks or greater in the adult, and greater than 4 weeks in children. And tomorrow I'm going to be talking a little bit about paediatric cough to the best of my ability. So cough receptors, neurons involved in cough have been long known, and guinea pigs have been the model, the animal model. In fact, if you ever come across this name, Whitcomb, John Whitcomb really is the godfather of chronic cough. I had the great pleasure to meet him. He sadly passed away about 10, 15 years ago. But Dr. Whitcomb did some really important work in guinea pig models and elucidating these sort of neural pathways in cough. But of course, predominantly the C fibres and the A delta fibres are the primary nerve fibres in cough. And since this was published in a book chapter in 1989, and this was one of the first sort of textbooks on cough, our knowledge of these neurons and the receptors involved have developed dramatically. So cough is mediated by sensory vagal fibres innervating the larynx and also the proximal airways. And so it's important to recognise that the cough reflex is one reflex, but we also have the expiratory reflex. We don't know much about the expiratory reflex, but the concept is that the upper airways are more sensitive to eliciting a expiratory reflex, which is essentially a cough without taking a big breath before it, which makes sense. If we deposit something in the upper airway, we want to expel it. We don't want to inhale it and then expel it. Whereas the neurons in the more peripheral proximal areas of the lung are responsible for the cough reflex. We don't have very good methods for delineating between the two. And it's not thought that that's important, although Dr. Whitcomb, in one of his last papers, wrote that perhaps it's really important that we work out ways of determining whether the cough reflex or the expiratory reflex is the most important in various cough phenotypes. So as I mentioned, C fibres, now these are important particularly for chemically sensitive stimuli, and A delta fibres for more mechanical stimuli. And so one of the interesting, if you do get an opportunity, this is a recently published review article by Jacqueline Smith, who is really a leader in chronic cough, particularly cough pharmacology. And she makes a nice point in relation to one of the troubles with developing drugs for cough, because of course it's a part of the central nervous system, and of course if we start to play around with that, we can have rather significant side effects. So we want to try to treat the peripheral nerves to minimise any central side effects, but one of the problems with that is that we have to work out what the right peripheral receptor is. But of course the knowledge in relation to this has evolved rather significantly. As I mentioned, over the last 10 to 15 years, we now know that there are a number of cough receptors at the terminal end of the C fibre that are important opportunities from a pharmacological perspective to block. So the concept is that we can block one of these or two of these receptors, for example. If we leave some of these other receptors active, we might be allowing the natural cough mechanisms to be maintained while suppressing the cough hypersensitivity in patients. And so this was sort of the concept in the development of these drugs. I'm going to talk about P2X3 inhibitors at the end of my talk, which is the new emerging drug that can be useful for treating chronic cough. However, there are a number of drugs in the pipeline that are helpful to block these other receptors. The other important aspect is true, as I mentioned earlier, is that with chronic cough, there are higher cough modulating area such that when we get exposed to whatever initiating stimulus that starts cough, and then of course the chronicity of cough changes, we get changes in the cough centres of the brain that change our cough threshold and of course drive that chronic cough or cough hypersensitivity syndrome. So as I said, the mechanisms now are better understood. So C fibres are probably the best target at the moment. As I mentioned, those receptors that I pointed out, there's of course the famous TRPV1 receptor, which is the receptor that capsaicin binds to. I'm always like coming to Thailand because the chili in Thai food reminds me of my TRPV1 receptors and how immature they possibly are compared to the Thai population. It's important to, so C fibres can respond to capsaicin, changes in temperature and pH. There is the TRPRA receptor as well that can, of course, respond to a number of different stimuli. That, for example, in perfumes, when patients are sensitive to perfumes, it's the TRPRA1 that is likely involved. But as I mentioned earlier, it's the P2X3 inhibitor that has helped us understand the role of adenosine triphosphate and the release of this in relation to endogenous mediators such as prostaglandin or bradykinin have helped understand that this particular pathway is also important in chronic cough. I won't say much about the A delta fibres, only that they are, as to remind you, mechanical stimuli are probably the most important driver of their responsiveness, airway mucus or an inhaled foreign body, for example, but they do also respond to changes in pH or lower or acid environments. So the cough guidelines, as a result of this knowledge, I think have developed appropriately. I'm not going to go into the entire cough guideline. My best advice to you is to read the cough guidelines and take your time to go through them. They're a very complex, I think, body of work that I think have played a really important role in helping us bring the understanding of better management to the clinical coalface. I'm going to talk about, of course, the ERS cough guideline talks about a number of very important areas of chronic cough, for example, in asthma, reflux, postnasal drip, cough as a result of ACE inhibitors, chronic cough in children, chronic refractory cough, cough in other diseases, and of course cough due to smoking. I'll talk about the ones in yellow. The others, there's lectures on their own in relation to these. I will just say that when it comes to chronic cough in children, there are a couple of, Chest have published a more recent updated version in 2020 from their original cough guideline in paediatrics in 2006. And of course, cough in children really shouldn't be considered as we consider adult cough. So the cough guidelines for children need to be read very carefully. And if you look at both of them, there's substantial differences. So asthma is a common driver of cough. We know that it's a common symptom. Wheeze, dyspnea, chest tightness and cough are probably the four primary symptoms in asthma. However, we now know that, of course, you can have cough variant asthma, in that there's some patients where cough is the only presenting symptom, which is rather fascinating, and I think we need to know more about it. But regardless, asthma can be a common reason for cough. Now, the cough guideline, of course, highlight that we really should be looking for objective measures to identify asthma, and I'm a strong advocate of that. However, the European Respiratory Cough Guideline is not a great fan of bronchial challenge tests, and there's historical reasons for this, and I think this will change in time. But effectively, they've spoken about trying to identify whether eosinophils are present, and eosinophilia is usually associated with the more severe end of asthma, but if it's present, of course, it's very helpful. We can identify, of course, sputum in eosinophils in sputum, but practically this is quite difficult to do. Not many centres do this, and so blood eosinophilia has become a surrogate for this more recently. Exhaled nitric oxide can be used, but it's important to understand that exhaled nitric oxide is not a direct marker of eosinophilia, it's associated with eosinophilia. Exhaled nitric oxide is liberated from the airway epithelium as a result of IL-4 and IL-13 driving STAT6, which is the enzyme that upregulates nitric oxide. So it's an indirect indicator of eosinophilia. I will say that when you start doing these objective measures, you will find patients with high levels of ENO and no eosinophils in their sputum, and of course high eosinophils and no ENO, particularly in the severe asthma setting. The important thing to add, though, is eosinophilic bronchitis, which is rather unusual. I must say, I think I can remember all the patients that I've ever seen with eosinophilic bronchitis. It's not that common. But one aspect of eosinophilic bronchitis is these patients do not have airway hyperresponsiveness. They often have very good lung function, but they produce mucus and they have plenty of eosinophils in their sputum, if we're able to measure it. This is where I think ENO and challenge testing might be helpful, because in these patients ENO might be high, but their airway hyperresponsiveness will be low. When it comes to refractory or unexplained cough, this, of course, is a separate entity. As I said, it may be due to existing disease, and we really need to understand whether we can treat at least an aspect of chronic cough as a result of the disease process. But what's clear is that if cough is not healed, it eventually makes its way up to tertiary care because of its inability to respond to therapy. And of course, chronic refractory cough, of course, is still a bit of a mystery to us. However, as I said, the new medications, the new neuromodulators, such as P2X3 antagonists, appear to show some promise in this particular area. However, opiates and gabapentin, I'll touch on this a little bit later, also can play some role in these patients. And there's emerging data for this, but we still need more research to really get an understanding of the role of these drugs in chronic cough and maybe some other areas of chronic cough. But just to remind you, of course, it's in this particular situation that there's aberrant neurophysiology that is likely to explain this condition, and thus the new term really for chronic cough, which is cough hypersensitivity syndrome. So of course, cough in other diseases is really important, and of course, much of this makes perfect sense. I just highlight that in our adult clinics in Australia, we often see cough presenting initially in idiopathic pulmonary fibrosis, and I'm often fascinated to see these patients who have early signs of cough. They may or may not have a dyspnea associated with it, and yet when they come into a respiratory laboratory and we perform a full screening test, it's fairly clear that lung restriction is definitely a feature. And I often follow these patients up. They've either been sent as a result of having a CT or they have their CT afterwards. And it's clear that these patients have interstitial lung disease. So the importance of doing full screening lung function testing is important, but particularly in this population. I just mentioned this can be sort of an area that is difficult. Chronic cough and tobacco. Of course, smoking can be a major cause of chronic cough that could be remediated if we can get our patients to stop smoking. And I think this it should be highlighted that we still need to be constantly vigilant of this. I'm working on some ways at the moment to try to improve this process of smoking cessation using titrated dermal patches. I'm working with a colleague in Australia at the moment on this, and we're trying to develop this area, which is one of the reasons I mentioned it. But it's always important to tell the patient that once they quit smoking, there may be a transient increase in coughing before the coughing suppresses, which is an interesting mechanism. Smoking appears to have some ability to suppress the cough reflex, and there's a study that's shown that it can suppress sensitivity to inhaled capsaicin. So just to sort of finish up on the guidelines, a lot of this is obvious. The guidelines stress that, of course, we need to work up. We need to exclude treatable traits. Of course, history, examination and investigation are the first places that we go. Understanding whether there's a malignancy or a foreign body or an ACE inhibitor playing a role needs to be the first port of call. Or, for example, in asthma, whether the introduction of an inhaled corticosteroid is going to play a major role before we go down the path of looking at neuromodulatory treatment. Again, the caveat being access to these treatments, which at the moment are still in their infancy. So these treatable traits can of course be, and these guidelines go through this rather nicely. Again, identifying eosinophilia, reflux, esophageal dysmotility, rhinosinusitis. And I think one area that also needs development is understanding upper airway dysfunction, and there may be a role, which comes first, the chicken or the egg? Did chronic cough cause the upper airway dysfunction because of the chronicity of this coughing mechanism, or is there something about the upper airway that started chronic cough? We still need to understand this more effectively, and we need better measurements for upper airway dysfunction, at least in the point of need. However, of course, ENT play an important role in this area as well. It's important to recognise that subjective cough measurement is important, particularly with the validated questionnaires. So a visual analogue scale, for example, or the Leicester Cough Questionnaire or a cough quality of life questionnaire are important, not just in terms of assessing the patient, but also reassessing and monitoring therapy I always think it's very important to show the patient the changes in scores, whether it be in asthma or any sort of outcome, to demonstrate if therapy has been effective, and to understand whether some of the maybe other reasons that a patient could be getting symptoms if their treatment is optimal. Guidelines all state that spirometry, of course, chest X-ray are central to the evaluation of chronic cough. Of course, CT is an option, but this comes after, of course, initial evaluation. The guidelines also state that, of course, it's important to do other tests beyond spirometry if possible, as I mentioned, gas exchange and lung volumes. They also talk about peak flow variability as being important, and this is an important outcome in asthma, for example. But when it comes to objective testing, as I mentioned, they talk about bronchial provocation testing, but the evidence is sort of still evolving in this area. But really, if you have active asthma and you have airway hyperresponsiveness, it's going to tell you that the airway is sensitive to an inhaled steroid. And I want to develop sort of the second part of my talk on this particular topic. Just to highlight again, full screening tests I think are very important in a cough clinic, because we really do want to know if a patient does present with restrictive spirometry, whether that restriction is due to gas trapping or it's due to a genuine reduced lung size. This is just an example in my clinic of a patient who presented with shortness of breath and cough. Was not on was taking Ventolin when they needed it, just through their own choice, and had a fairly significant bronchodilator response on the day. So cough challenge testing is an area that has played a big role in understanding cough mechanisms, but its translation into the clinical space has been quite slow. That's because of an unknown. Its application is unclear because of the many different potential cough phenotypes, and some of these chemicals that we give, whether it's capsaicin or acid, target different nerves. But of course, regardless, these cough provocation tests have helped us a lot to understand the mechanisms. So as I said, capsaicin, citric acid, tartric acid, AMP, but we can also use osmotic challenges. So we can get someone to exercise, for example, and that can bring on cough in some patients. Of course, if we give hypertonic saline, I'm going to talk about inhaled mannitol in a moment, these osmotic stimuli can also provoke cough. And the TRPV4 receptor is one receptor that's influenced by osmotic change. However, I'm going to talk about probably an opportunity that might come in that the mannitol challenge does cause some cough in patients, and it appears that cough might identify cough hypersensitivity syndrome. The ERS guidelines, of course, go through this, and they're encouraging, of course, the need to develop objective measures for cough. And I think this provides an important opportunity, but it's important to understand that there is also the development of new technologies that are coming online. These automated cough recording technology we might see will play a role in the future. In fact, I haven't got my mobile phone with me, but there's a company in the United States where you can has an app that you can download, and the patient can keep the phone with them, and it records covertly the patient's cough, and they're learning. They're trying to use AI algorithms to determine cough characteristics in a patient, but also monitoring patients. So we're going to see our mobile phones playing a big role, I think, in elucidating mechanisms, understanding phenotypes, and looking at response to treatment. So as I said, it's an evolving area. As I mentioned earlier, the mannitol challenge, I spoke about this yesterday in relation to the diagnosis of asthma, and of course this has now been well established. This was my PhD project many years ago, and of course now it's a product that is available and registered by the FDA. It's in Europe, of course in Australia, and we're hoping it can come to Thailand next year. But of course it's a bronchial provocation test that identifies airway hyperresponsiveness, which is a key feature of asthma, but it identifies airway hyperresponsiveness that is steroid sensitive. And this is very important when we need to make the clinical decision, do we need to treat with an inhaled corticosteroid? But one of the interesting side effects, as I mentioned earlier on, or side effects in inverted commas, is cough. And in some patients, you can get cough with or without bronchospasm. And so one of the conceptions I have at the moment is, of course, if you have bronchospasm and you cough, that is a cough, inhaled sensitive cough. Whereas if you don't have bronchospasm and cough, it is likely going to be an indicator potentially of neuromodulation treatment. This work needs to be done, but I'm going to show you some work that might show that there is some hope here. So how we cause the airways to narrow due to osmotic change was discovered by understanding the mechanism of exercise-induced bronchoconstriction. As we exercise, we increase our rate of breathing, we lose water moisture from our breath. That's a very important pathway, of course, for the body to lose heat. But if you increase you decrease airway, the water content of the airway surface, you increase the airway osmolarity. This causes the release of mediators from inflammatory cells in the airways if they're present, such as the mast cell and the eosinophil. These mediators then act on the airway smooth muscle via specific receptors to cause the airways to narrow. But people, as I mentioned, cough, and the cough might be due to either osmotic stimuli directly on airway sensory nerves, as I mentioned, the TRPV4 receptor, mediator release, so prostaglandin D2, leukotrienes may play an important role at augmenting cough sensitivity. But we also know that bronchial smooth muscle contraction is an important driver of cough as well. There's a number of stimuli here that can drive coughing in patients if they happen to cough. I should add that if you have a normal, healthy young person doing a mannitol challenge, you don't get any cough whatsoever. So cough appears to be associated with an underlying process, and we need to learn more about this. So I won't get into it in great depth, but the understanding of osmolarity and cough sensory nerves is quite well established. Non-isotonic stimuli, of course, worked out in the 80s that could provoke cough. Being exposed to fog, for example, on a cold, foggy day, which I don't think happens too often in Thailand, but in the UK, where these studies were done, this is what happens. And we know that rapidly adapting receptors are important. The mast cell histamine might play a role in this particular, in some cases, as I mentioned, the release of mediators. Inhaled mannitol releases a rather potent cough molecule called 15-HEAT, and that comes from the epithelial cell, and it can activate C fibres. So there is a number of different mechanisms that might drive cough to osmotic stimuli. And as I just mentioned briefly, this is just a schematic of the figure that I showed you earlier, just highlighting that one key characteristic of a mast cell and an eosinophil is they don't like dehydration. And when you dehydrate the mast cell, it will release preformed histamine and cause the de novo synthesis of prostaglandin D2 and leukotrienes, whereas eosinophils will produce leukotrienes. So if you have more severe airway inflammation, you have the addition of eosinophils on top of your mast cells, you've got more mediator to cause the airways to narrow. I should just also add that you really need IgE on the surface of the mast cell to make it a lot more osmotically sensitive. So I won't get into the asthma story, but I'll just give you, I think, an important example. This is a young military recruit, interestingly, who has asthma, very good lung function, and he came and did a mannitol challenge, and he responded to 60, 70 milligrams, which is not very much. So I could get his airways to narrow very well, very easily. He was on no medication. This fellow had childhood asthma. He had no symptoms of asthma, and this is one of the reasons why we screen these recruits, because you can have childhood asthma, you can get into your teenage years and be symptom-free, but still have underlying pathology. So this young fellow came in, he had active asthma, we sent him off for his inhaled steroid therapy for 3 months, and of course he comes back in 3 months. These guys take their medication every day. They're motivated to get into their chosen profession. And so in about 3 to 4 months, we could completely block his airway hyperresponsiveness. You can't see it clearly here, but this fellow had an FEV1 of, I think, 95% of predicted, and he went up to 110% of predicted. So while he came in with normal lung function, it wasn't his normal lung function. His normal lung function was much better. So identifying someone who has this response with cough, inhaled steroids might play a role also at dampening the cough response. I'm just going to show you some data on the mannitol challenge and cough. I should just highlight that the cough stimuli that exist that have been used in research, as I said, capsaicin, citric acid, and tartric acid, none of these stimuli can differentiate cough in healthy and asthma. So a healthy person and an asthmatic will cough to these stimuli, but we've now found that osmotic challenge is the only challenge that can differentiate asthma and healthy subjects. So this is some early studies that I did in the mid-2000s with mannitol. As you can see, the asthmatic subjects cough a lot more than the healthy subjects who really don't cough much at all. And 60% of the coughing occurs before a significant change in FEV1. So there is an underlying neural hypersensitivity going on when we change airway osmolarity. Of course, the number of coughs, when we look at it numerically, are significantly higher, a mean of 50 versus 12. So you see really significant increases in cough sensitivity in asthmatics. When we treat the asthma with inhaled steroids, the cough response to mannitol reduces, and so the total cough will reduce, and also that partial cough, that cough before you see bronchospasm, also reduces with inhaled steroids. So it suggests that inflammation is playing a role in this cough hypersensitivity. We did some studies many years ago. I know chromoglycate and nodochromal sodium mast cell stabilizing drugs are not used much these days, but these drugs are extremely effective at blocking mast cells and stabilizing mast cell from mediator release. We showed that if we give nodochromal, in this case, to a patient before a mannitol challenge, we can shift their dose response curve, so we can improve their airway hyperresponsiveness. And in fact, if you have milder airway hyperresponsiveness, we can block it. So there's a relationship in relation to baseline severity. But when it comes to cough, there's this is airway hyperresponsiveness. So this is just another way of expressing airway hyperresponsiveness. So we can suppress airway hyperresponsiveness with nodochromal and of course placebos at the top. But when we look at cough as an outcome, there's no difference. So the mast cell, when we block the mast cell, it's not playing a role in the cough response to mannitol, which is interesting. There may be other factors involved, such as bronchospasm or direct activation of sensory nerves. So this direct activation of sensory nerves is rather fascinating. I did all my research in asthma. I went overseas and did a postdoc, and then I came back to Australia when the mannitol challenge was available in Australia. I walked into a respiratory laboratory and I saw a woman coughing to the test that I've never seen before. And I asked my boss at the time, I said, "This is fascinating." I said, "I've never seen this." And she says, "Oh, it happens all the time in middle-aged women who are overweight." So I thought this cough response is a signal. It's not an inconvenience. It's not a side effect. It's telling us something. So we did a study in that laboratory where we videotaped patients. We videotaped a small number of healthy subjects, but we divided all the patients in the laboratory who had cough symptoms and who didn't have cough symptoms. And we looked at the differences. And what was fascinating is that initial observation of my PhD supervisor was completely correct. Middle-aged women, I should say, who are overweight were more likely to have this heightened cough hypersensitivity, which of course is in keeping with the population that suffer from cough hypersensitivity syndrome. So we published this as a letter in 2018, and then we dived into doing a study. Oh, I should just highlight, we did find a relationship in this study with the Leicester cough score, but just to highlight in the yellow there, the differences between cough sensitivity of the coughing patients versus the other symptoms in the healthy were all statistically significantly greater. So we did a study to see whether if we have a mannitol challenge that can identify asthma, we might have a test in the clinic that we can identify cough hypersensitivity. So the best thing to do is to compare it against an established cough test. And so we looked at citric acid, and we did this study in Finland, and the ethics committee wouldn't allow us to use capsaicin and the regulatory authority as well, because it was deemed to be harmful. We had to use citric acid. And so citric acid, of course, has been established, at least in research. It's not used clinically as a test. And it fires the C fibres, particularly the TRPV1 receptor, is probably playing a role as a result of changes in airway acid. And so we compared it to the mannitol, and I touched on this before. This is less known, but there are some studies to demonstrate that osmotic stimuli can drive cough, and possibly both the A and C fibres, so the mechanical fibres might be playing a role in osmotic cough as well, but this is what we needed to determine. So we did a study, we compared chronic cough in healthy patients, and we recruited them to do the two challenge tests, the citric acid and the mannitol, and there were very similar characteristics between all of the patients, other than the chronic cough being heavier, having slightly lower FEV1, but it was in the normal range. Now, one thing in cough is cough can actually be quite an interesting and simple test potentially, because you can give a stimulus and just measure the dose of a concentration to give 2 or 5 coughs. But potentially you could do quite a quick test if we had something available for this purpose. So that is one outcome, but we also look at the outcome, particularly with a mannitol challenge, in terms of the cough that we experience throughout the whole challenge test. And so what was interesting in this study is we found significant similarities between both cough and citric acid, so they both caused chronic cough, increase in cough hypersensitivity and chronic cough, whether we looked at the total cough that was experienced during the test, or the C5, which was just the dose that caused either 2 or 5 coughs. So there were similarities in the responses. There was an interesting relationship that was significant between the two stimuli. And then if we looked at their diagnostic sensitivity, when we had both, of course, healthy and chronic cough patients, the diagnostic sensitivity was similar for both citric acid and the mannitol when it came to identifying chronic cough. So it shows some potential that this side effect with mannitol might actually be a useful clinical indicator for identifying hypersensitivity syndrome. So I'm just going to quickly, in the time remaining, just talk briefly about existing therapies and their advantages and disadvantages. So the two I'll talk about is, well, firstly, low-dose morphine sulfate, and it appears the low dose is important. There's been a couple of studies that have shown this, but effectively in 3 prominent studies, they've demonstrated a significant reduction in cough hypersensitivity in these patients with chronic refractory cough. And these studies are worth looking at. There's a double-blind RCT, and they're usually done in small single centres, unfortunately. Multi-centre studies have not been done with existing therapies because, of course, there's no pharmaceutical company willing to fund such a study. But they've seen fairly significant reductions in cough hypersensitivity with this treatment. Of course, the problem is potential for opioid abuse. It's unclear why a low dose is effective, but in Europe, it's used more common than, for example, in the United States, where there's a concern for, of course, opioid addiction. But of course, we do have, as I said, we do have something we can use at the moment to treat cough, but there are, of course, conditions in relation to potential unwanted side effects. And speaking of this, of course, this is also relevant for gabapentin. This is a calcium channel blocker. Of course, has an established role in seizures and neuropathic pain. And of course, there's some limited studies at the moment for this, but this drug both has central and peripheral action, so you can have significant side effects such as sedation and unsteadiness. And of course, one of the interesting aspects of these drugs is that they haven't been able to elucidate the mechanism fully, because you can get effects on mood and anxiety, and it's thought that perhaps the changes there might be driving the subjective cough outcomes. So this has been the reason for trying to develop new drugs that are specific to chronic cough. And of course, gefapixant is the drug that is now available, but only in Europe and Japan and Switzerland. Now, I'll talk about this in a moment, but of course this blocks the P2X3 inhibitor. Of course, the availability of these drugs is going to be limited, so they might be approved, but whether we end up seeing them in Australia or Thailand remains to be seen, for example, because of course there may be other health economic assessments that prevent their utility. And I guess one of the key concerns is that if cough is a major presenting clinical symptom, these drugs could be overprescribed, and so regulatory authorities are quite concerned, and they want a marker for chronic cough, and I think this is where the mannitol test might be potentially useful to identifying these patients. I will just say though that these studies are rather fascinating in that they've identified a large placebo effect in some patients. So there is a potential opportunity that cough can heal by itself, or that we can intervene with some sort of placebo strategy, but we need to know who these patients are. So in the pipeline at the moment, of course, this gefapixant has developed, but it has not been approved in the United States, and it wasn't approved in the United States because of the placebo effect. However, Glaxo have just purchased this second one, of course, camlipixant. This drug might be the one to watch because they've worked out what they did wrong in the first study in terms of patient recruitment, and they may improve the patient selection with the newer drug, and we might see that might be approved and play a more significant role. Of course, there are other receptors that are being investigated at the moment, and these are all in early stages, but of course they're blocking various receptors at this nerve terminal. The important thing to remember is that one of the big side effects of a P2X3 inhibitor is you use your ability to taste food, and that loss of taste is a problem in these studies because the patient can become unmasked, and we think that it's thought that lower doses may be better tolerated. We can if we lower the dose, we may get less of that side effect, but it's still an important side effect. So I'm just going to finish up by saying that, look, I think there's an interesting space to move into in terms of developing laboratories that are specifically used for investigating chronic cough and understanding whether other disease processes are in place. And a respiratory laboratory might be one place, at least by able to measure spirometry, gas exchange and lung volumes. We can do bronchial provocation testing in these environments. We can measure exhaled nitric oxide. We can give the patient questionnaires, and we can use electronic cough monitors and perform allergy testing. And I think collecting as much information as we can on our patients and monitoring them over time might help us understand different phenotypes. So I'll conclude on that point just to state that, of course, guidelines are important. We need to constantly look at them, and they need to be revised. But I think the emergence of objective measures might help with these in the future, as well as new pharmacology. So on that note, I'll finish. Thank you for your attention.
ก็เรื่องที่จะพูดนะคะสั้นๆง่ายๆแต่เป็นเรื่องใหม่แล้วก็พูดเวทีนี้เวทีแรกนะคะก็คือเรื่องไทย Cough Guideline นะคะซึ่งอันนี้ก็เกิดจากความร่วมมือของอาจารย์จากทีมหลายๆคนนะคะมาทำด้วยกันนะคะซึ่งยังไม่ได้เปิดตัวที่ไหนนะคะเพราะว่ายังไม่เสร็จแต่ใกล้เสร็จแล้วค่ะนะคะซึ่งนี้ก็เป็นทีมที่ทำเรื่อง Cough Guideline นะคะก็เป็นอาจารย์จากหลายสาขานะคะนั่งอยู่ที่นี้ก็มีพี่พงศกรนะคะคุณจรเขาอยู่ในทีมนะคะแล้วก็มีอาจารย์เอ็มมีหลายคนอยู่ในทีมซึ่งมีทั้ง Chest ENT คือ Cough เนี่ยเป็นเรื่องที่มันเป็นทั้ง Airway Upper Lower มี GI มีอะไรนี่ก็เป็นทีมที่ทำแล้วก็รวมถึงทีมของอาจารย์ที่ทำสถิติด้วยนะคะวิธีทำงานของเราก็คือว่าเราเริ่มทำตั้งแต่ต้นปีเราต้องเสร็จภายในเดือนนี้เพราะว่าเราจะต้องตีพิมพ์แล้วเพราะเป้าหมายคือต้องตีพิมพ์นะคะงั้นเราก็ทำงานด้วยกันประชุมกันเกือบทุกเดือนแล้วก็มีการประชุมออนไลน์ด้วยโดยให้อาจารย์เกียรติซึ่งแบบเจ้าพ่อเลยนะคะอาจารย์เกียรติเนี่ยก็เป็นประธานแล้วก็เป็นที่ปรึกษาของเรานะคะ นอกจากนี้เราก็จะมี international expert team นะคะซึ่งมาเป็นคนให้ความคิดเห็นนะคะก็มีคุณจอห์นนะคะแล้วก็อีกท่านหนึ่งนะคะซึ่งมาจากเกาหลีวูซุงใช่ไหมคะซึ่งคนนี้เนี่ยเขาเป็นคนจัดตั้ง Cough Clinic แล้วก็เป็นคนเขียน AIS Guideline ด้วยนะคะซึ่งนี่ก็จะเป็นเจ้าพ่อแล้วก็มาช่วยกันเขียนเปเปอร์แล้วก็คอมเมนต์ด้วยกันนะคะทีนี้มาดูเรื่อง Cough Guideline นะคะว่า Cough Guideline เนี่ยจริงๆมันก็มีคนทำทั่วโลกนะคะทั้งของออสเตรเลียบริติชของ ARS ของจริงๆของจีนน่ะเขาเขียนดีละเอียดนะคะแล้วก็รวมถึงของไทยเนี่ยเรามีเมื่อปี 2559 เป็นกี่ปีแล้วว่ะนะคะแล้วก็เราจะอัปเดตปีนี้นะคะซึ่งวันนี้ก็จะมาสรุปที่อัปเดตนะคะโดยอัลกอริทึมเนี่ยเราจะเริ่มจากอันนี้อาจารย์เอ็มก็เป็นคนช่วยคิดนะคะเป็น cough management process นะคะเราเน้น assess adjust แล้วก็ review นะคะคำว่า assess ก็คือเราต้องดู severity เหมือนที่คุณจรพูดนะคะเพราะว่าเวลาเราทำ treatment ไปแล้วอ่ะ intervention ไปแล้วเราจะได้ดูคนไข้ดีขึ้นหรือเปล่ามันต้องมี assess อาจจะดูเป็นสกอร์ก็ได้เป็น WAS สกอร์ก็ได้หรือเป็น cough questionnaire แล้วก็นอกจากนี้ assess ดูเรื่องประวัติแล้วก็ดู red flag นะคะว่าคนไข้มีความเสี่ยงหรือเปล่าดู comorbid นะคะแล้วก็ assess ว่า investigation อะไรบ้างแต่แล้วหลังจากนั้นก็ adjust ซึ่งเดี๋ยวจะพูดอีกทีนึงค่ะ adjust ดูว่าคนไข้cough ดีขึ้นหรือยังแล้วก็ adjust treatment ตาม specific disease นะคะแล้วก็ให้คำแนะนำอย่างเช่นเมื่อกี้เรื่อง smoking cessation ลดเรื่องงดบุหรี่ต่างๆนะคะแล้วก็รีวิวเพื่อดูว่าถ้าทำแล้วไม่ response เราต้องแดกใหม่ไหมแล้วก็ response to treatment นี่ก็คือเป็น algorithm approach คือของเราจะต่างกับอันอื่นยังไงคะส่วนใหญ่เนี่ยอันอื่นเนี่ยเขาก็จะ approach ในคนไข้ที่เป็น chronic cough ที่เกิน8 week แล้วก็บอกเลยว่าต้องทำอะไรบ้างแต่ของเราเน้นว่าให้รักษาคนไข้ chronic cough ได้เพราะฉะนั้นเราจะเน้นเรื่อง algorithm ว่าถ้าคนไข้ chronic cough เนี่ยเราต้องซักประวัติอะไรบ้างตรวจร่างกายอะไรบ้างเพราะถ้าเราซักประวัติตรวจร่างกายดีเนี่ยเราจะสามารถ direct ได้โดยไม่จำเป็นต้อง investigate แบบจัดเต็มนะคะถ้าใครอ่าน chronic cough guideline มาหลายๆประเทศเขาจะไม่ได้เน้น algorithm เขาจะเน้นว่า chronic cough investigate โน่นนี่แล้ว therapeutic trial อันนี้ก็เป็นไอเดียของอาจารย์เกียรตินะคะอาจารย์เกียรติอยากให้จริงๆ chronic cough มันเป็น upper airway เยอะไม่จำเป็นต้องฟิล์มเชสก็ได้เพราะฉะนั้นเนี่ยถ้าเราซักประวัติดีๆเราก็สามารถแยกโรคได้นะคะนี่เป็นวิธี approach นะคะว่าถ้าเป็น chronic cough นี่หาอ่านที่ไหนไม่ได้นะคะเพราะว่าเพิ่งพูดวันนี้วันแรก ถ้า cough 8 อาทิตย์ขึ้นไป chronic cough สิ่งที่เราต้องประเมินก็คือ red flag ก่อนนะคะว่ากลุ่มนี้เนี่ยถ้ามีกลุ่ม red flag ปุ๊บเนี่ยแสดงว่าเป็นไงคะแสดงว่าเป็นโรคที่มัน life threatening ร้ายแรงอันนี้ใช้ไม่ได้เลยนะคะเพราะฉะนั้นเนี่ยเราอาจจะต้องดูอะไรบ้างบอยอยากใช้เลเซอร์ค่ะอย่างเช่น hemoptysis chest pain เสียงแหบกลืนติดหรือมี seismic symptom นะคะ recurrent pneumonia DSAT cupping finger ไอ้พวกนี้ถ้าเป็น red flag ปุ๊บเนี่ยเราต้อง investigate ไปเลยนะคะแต่ว่าถ้าไม่มี red flag ทำไงบ้างเราก็ดูเรื่องบุหรี่ซักประวัติตรวจร่างกายนะคะถ้าคนไข้ทานทานพวกยากลุ่ม hypertension นะคะ inhibitor แล้วก็อาจจะเป็นดัก induced cough พวกนี้ลักษณะก็คือไอแห้งๆนะคะซึ่งวิธีการก็คือเปลี่ยนยานะคะถ้าคนไข้มีจามน้ำมูกคันคัดจมูกเสมหะไหลลงคอหรืออาจจะเป็น Asthma Nasal symptom นะคะอย่างเช่นคันจมูกคันตาพวกนี้ก็เป็น allergic rhinitis เห็นไหมคะว่าไม่จำเป็นต้องฟิล์มเช็ดทุกรายเพราะว่าถ้าเป็นไกด์ไลน์อื่นไอเกิน8 วิต้องฟิล์มเช็ดก่อนถ้าคนไข้มีน้ำมูกสีเปลี่ยนปวดไซนัสกลิ่นไม่ได้กลิ่นก็เป็นไซนัสถ้าคนไข้มีไอกลางคืนมีวีสช็อตเน็ตอัปเบรดก็ให้สงสัยแอสมามีประวัติเป็นฮาร์ดเบิร์นอีพิแคสติกเพนหรือก็ใช้เกิร์ดถ้ามีเสียงเปลี่ยนไอแห้งๆก็ให้คิดถึงลาริงเจียลไฮเปอร์เซนซิทิวิตี้นะคะแล้วก็ถ้าคนไข้เป็นรีคอร์เมนเนียเป็นทีบีก็อาจจะเป็นมองคีเอ็กทิซิสหรือเปล่าหรืออันนี้เป็นจอห์นเขาเลขคอมเมนต์นะคะ this is your suggestion about the ILD persistent cough progressive worsening dyspnea ก็จะเป็น ILD ได้นะคะหลังจากนั้นถ้าเราสามารถซักประวัติแล้วก็ตรวจร่างกายแล้วสงสัยโรคอะไรเราอาจจะ therapeutic trial ไปก่อนหลังจากนั้นเราก็ treat เป็น probable cause นะคะก็คือไม่เห็นก็คือ treat โรคที่เรานึกถึงนะคะถ้า treat แล้วไม่ดีขึ้นแล้วให้เวลา2 อาทิตย์แล้วก็ค่อยฟิล์มเช็ดแต่ถ้าประวัติชัดเราไม่ต้องก็ได้แต่ว่าหรืออาจจะ investigate ตามโรคที่เราสงสัยทีนี้ถ้าทุกอย่างปกติประวัติไม่ชัดมีแต่ไออย่างเดียวทุกอย่างไม่นึกถึงอะไรเราจะ investigate ตามต่อไปนี้นะคะซึ่งแต่ละ investigate ก็จะมีพิโคบอกว่าอันนี้ควรทำไม่ควรทำอย่างเช่นเป็น Nasal endoscopy ถ้าคิดถึง upper นะคะ laryngoscope ต้องทำไหมในพิโค question เนี่ยมันก็จะบอกว่ามี evidence based practice อะไรบ้างแล้วก็เราจะเป็นให้เป็น strength of recommendation spirometry เนี่ยควรทำทุกรายถ้าทุกอย่างปกติแล้วก็อาจจะทำ peak variability ได้ถ้าไม่มี spirometry แล้วก็ฟีโนเนี่ยควรทำเพราะฉะนั้นถ้าคนไข้มีไอเรื้อรังทุกอย่างดูปกติเราก็ต้องทำ exhale nitric oxide ด้วยนะคะแล้วก็นอกจากนี้ถ้าคนไข้ spirometry ปกติแล้วก็ฟีโนต่ำกว่า25 cut off point เราเอา25นะคะเราก็ทำ bronchial challenge อย่างเช่นทำ mannitol challenge นี่ก็คือสิ่งที่คุณแบนนันเขาก็ให้ recommend บอกว่าbronchial challenge เราจะทำต่อเมื่อ spirometry หรือฟีโนเนี่ยมันไม่ได้บอกข้อมูลอะไร This is your idea for the bronchial challenge หลังจากนั้นถ้า investigate เจอแล้วก็ treat ตาม specific นะคะอย่างเช่นว่าถ้าเรา investigate ทุกอย่างปกติเราอาจจะ try out ได้ซึ่งเดี๋ยวจะดู evidence based ถ้าคนไข้มีอาการเหมือน allergic rhinitis มี upper airway cough เราก็อาจจะ treat allergic rhinitis อย่างเช่นดูคะแนน WAS ก็คือเดี๋ยวพี่เป้งอาจจะพูดอีกทีใช่ไหมคะก็คือเดี๋ยวอาจารย์พงศกรจะพูดอีกทีหนึ่งถ้าเป็น upper airway cough หรือว่า sinusitis ก็จะมีเทคนิคในการ treat เดี๋ยวจะให้ hand out ไว้นะคะแล้วก็ cough variant asthma cough variant asthma ก็คือคนไข้ไอเรื้อรังที่อาจจะเป็น asthma โดยไม่หอบซึ่งพวกนี้เนี่ยบางครั้งสไปโรอาจจะปกติหรือผิดปกติก็ได้ฟีโนอาจจะเกิน25ก็ได้แต่ว่าถ้าเราตรวจทุกอย่างปกติเนี่ยจริงๆอาจจะทำ bronchial challenge แต่ถ้าทำไม่ได้เราอาจจะ therapeutic trial เป็น cough variant asthma ไปเลยก็ได้อย่างเช่นให้ ICS หรือ ICS-LABA หรืออาจจะ add on anti-leukotriene อีกอันนึงมีเทอมเขาเรียก non asthmatic eosinophilic bronchitis จริงๆไอ้ตัวเนี้ยก็ใช้สเตียรอยด์แต่อาจจะใช้โดสสูงหน่อยหรือว่าถ้าคนไข้มีเกิร์ดทรีตแบบเกิร์ดนะคะซึ่งมันก็จะมีพิโค recommendation ว่าแต่ละข้อเนี่ย recommend ว่าควรทรีตไม่ควรทรีตหลังจากนั้นเสร็จเราก็จะรีวิวการรักษาที่ประมาณ 2-6 อาทิตย์เพราะว่าบางโรคเนี่ยให้2อาทิตย์อาจจะไม่ดีค่ะต้อง6อาทิตย์ไปนะคะแล้วก็ดูคนไข้ว่า response ดีไหมถ้าไม่ response อาจจะต้องวนลูปมา evaluate ใหม่ทีนี้มาดู pico question นะคะในไกด์ไลน์เราก็จะเอา evidence based practice เพราะฉะนั้นเนี่ยpico question เนี่ยมันก็จะช่วยบอกว่าสิ่งที่เราจะทำเนี้ยมี evidence based น้ำหนักมากน้อยแค่ไหนแล้ว approach ตาม algorithm ใช่ไหมคะอย่างเช่นว่าพิโคเนี่ยมันจะแบ่งเป็นพาร์ทที่เป็น investigate กับพาร์ท treatment นี่ตัวเองยกตัวอย่างทั้งหมดจริงมี20กว่าข้อนะคะรีวิวเปเปอร์กันเป็นพันนะคะเพราะว่าเนื่องจากเป้าหมายหลักๆเราต้องการรีวิวว่ามันแต่ละอันที่เราทำมี evidence based มากน้อยแค่ไหนถ้าไม่มีเราก็จะทำวิจัยเพิ่มถ้าไม่มีแต่ถ้ามีแล้วมันก็เป็น strong recommendation อย่างเช่น Nasal endoscopy คนทำหรือเปล่านะคะหรือว่าเป็นฟิล์มไซนัสควรทำไหมนะคะอย่างเช่น CT ควรจะทำหรือเปล่าถ้าคนไข้ normal chest นะคะฟีโนควรจะทำหรือเปล่านะคะยกตัวอย่างหรือบัตร eosinophil หรือตัวเองจะเอายกตัวอย่างว่าที่เราทำมาอย่างเช่นว่าฟิล์มไซนัสเนี่ยเขาบอกว่าในchronic coughควรทำไหมเขาบอกว่าถ้าไม่มีอาการอะไรไม่ต้องทำก็คือถือว่า weak again ก็คือไม่ให้ทำเป็นรูทีนถ้าคนไข้ไม่มีอาการที่ส่งบอกว่าไซนัสอย่างเช่น CT chest ถ้าคนไข้ฟิล์มเช็ดปกติเราก็ไม่ต้องทำนะคะถ้าคนไข้ไม่มีอาการที่สงสัยว่ามีปัญหาเรื่อง lower airway นะคะ weak against ก็คือไม่ได้เป็น routinely ทำ CT chest ทุกรายนะคะแต่ฟีโนที่ evidence based เยอะๆก็คืออย่างเช่นฟีโนนะคะเดี๋ยวฉบับเต็มเนี่ยเดี๋ยวทำเสร็จเดี๋ยวจะให้อ่านกันนะคะอันนี้แบบกำลังเขียนอยู่ฟีโนเนี่ยมันเป็นอันเดียวที่มี strong recommend ว่าฟีโนเนี่ยจะช่วยในคนไข้ chronic cough เนี่ยจะช่วย predict ว่าคนไข้เป็น steroid responder หรือเปล่าเพราะในคนไข้ไอเรื้อรังแบบเป็น upper กับ lower ใช่ไหมคะถ้า lower ถ้าคิดถึงพวก covalent asthma หรือเป็น non asthmatic eosinophilic bronchitis เราต้องให้ ICS เพราะฉะนั้นก่อนให้เนี่ยเราควรจะทำฟีโนก่อนฟีโนก็ predict ว่าเป็น steroid responder หรือเปล่าซึ่งฟีโนเราก็เอาเกิน25แต่ถ้า diagnose asthma เราจะ50แต่ว่าถ้าใน chronic cough เราเอา25บอกเป็น steroid responder มันมี strength recommendation ชัดเจน evidence based มากที่สุดนะคะสมมุติ part treatment นะคะ part treatment ก็มีตั้งแต่สมมุติไอเรื้อรัง non specific แล้วทำไงบ้างแล้วก็อาจจะศาสตร์ไปเลยให้ทั้ง anti histamine นู่นนี่มันมี treatment ที่เราให้เยอะมากแต่จริงๆเวลา treat เราต้อง step treat ว่าเราคิดถึงอะไรก่อนนะคะถ้าเราศาสตร์ทุกตัวเวลา approach เราจะไม่รู้คนไข้ดีจากอะไรนะคะนี่ตัวเองจะยกตัวอย่าง ว่าอย่างเช่นนะคะการล้างจมูกช่วยไหมใน chronic cough เขาบอกการล้างจมูกจริงๆ evidence ถึงแม้ไม่ได้เยอะมากเป็น strong เพราะว่าน้ำหนักมันชัดเจนว่าในคนไข้ที่ไอเรื้อรังจาก upper airway cough syndrome เป็นพวกโรคนาซัลดิบเนี่ยการล้างจมูกเนี่ยก็คือว่ามีประโยชน์แต่ถ้าไม่ได้มี upper airway cough syndrome ไม่มี post nasal drip การล้างจมูกไม่ได้ประโยชน์นะคะอย่างเช่นเดี๋ยวแอนติฮิสตามีนเดี๋ยวพี่เป้งที่อาจารย์พงศกรจะพูดว่าเรื่องไอเนี่ยแอนติฮิสตามีนช่วยไม่ช่วยอย่างเช่นการใช้ ICS เขาบอกว่าถ้าเกิดว่าสมมุติถ้าเราทำฟีโนไม่ได้นะคะเทเลปติกทริอัลด้วยการใช้ inhale corticosteroid เนี่ยมีประโยชน์ในการทำเพราะฉะนั้นถ้าเราเจอคนไข้ไอเรื้อรังเราเวิร์กอัพก่อนฟิล์มเชสสไปโลฟีโนถ้าฟีโนสูงก็ให้ ICS แต่ถ้าเราไม่มีฟีโนเราอาจจะต้องเทเลปติกทริอัลที่มีน้ำหนักมากที่สุดก็คือใช้ inhale corticosteroid แต่ว่าต้องตัด upper airway ออกให้หมดนะคะเพราะว่าคนไข้อาจจะเป็น upper ก็ได้นะคะอีกอันนึงก็คือ anti leukotriene จริงๆ anti leukotriene เนี่ยถ้าเป็น chronic cough ที่ไม่ใช่ cough variant asthma เนี่ยน้ำหนักน้อยนะคะก็คือว่า weak recommendation แต่เป็นเขาเรียก conditional strong conditional recommendation ถ้าคนไข้คิดถึง cough variant asthma นั่นหมายถึงว่าก่อนจะให้ anti leukotriene อาจจะต้องให้ทั้งสไปโลฟีโนไปแล้วแต่ถ้าไม่ใจอาจจะ add on เพราะว่าในคนไข้ที่เป็น chronic cough จาก non asthmatic eosinophilic bronchitis เนี่ย ICS มันจะได้ผลดีกว่าเพราะ ICS จะช่วยทั้ง asthma cough variant asthma กับ non asthmatic eosinophilic bronchitis แต่ต้องให้โดสสูงหน่อย start dose จะสูงหน่อยถ้าเป็น asthma เริ่มจาก low dose ใช่ไหมคะแต่ถ้าในไอเรื้อรังICS เราต้องให้โดสสูงหน่อยแต่ว่าถ้าเป็น anti leukotriene นะคะก็ได้ผลดีใน cough variant asthma อาจจะเป็น mono หรือ add on แต่ถ้าดูไอทั่วๆไปเนี่ยevidence base ไม่ได้ชัดเจนแต่ว่าอาจารย์เกียรติชอบพูดเสมอว่าไอรังเป็น upper มากกว่า lower เพราะฉะนั้นอย่าลืม assess upper airway ให้ละเอียดนะคะซักประวัติแล้วอาจจะที่คิดถึง upper ทะเลปิด trial upper ทีนี้ anti reflux เราก็ชอบศาสตร์ไปใช่ไหมคะถ้าคนไข้ไอเรื้อรังให้ไปเลยที่เกิร์ดใช่ไหมคะก็เป็น strong again ก็คือไม่แนะนำให้ใช้ถ้าคนไข้ไม่มีอาการที่สงสัย refluxซึ่งไอเนี้ยในพาร์ทเราก็มีอาจารย์มนทิลาที่เป็น GI จากจุฬาเขาก็บอกว่าจริงๆเนี่ยแนะนำว่าถ้าทำได้ก็ควรจะ investigate เรื่องเกิร์ดก่อนแล้วถ้าคนไข้ไม่มีอาการเกิร์ดเลยเราก็ไม่ให้ empirical treatment เพราะว่าไม่มีประโยชน์อันหัวใจสำคัญในคนไข้ไอเนี่ยต้องมี screening questionnaire สักประมาณ upper lower GERD เนี่ยครบก่อนที่เราจะรักษาบางทีเราไม่ได้เน้นการซักประวัติแต่อาจารย์เกียรติก็แนะนำบอกว่า screening questionnaire สำคัญมากอันเราก็ควรมี screening questionnaire ในอัลกอริทึมที่ดูนะคะก็คือเป็น AR sinus GERD อย่างนี้ต้องการสูบบุหรี่การใช้ยาพวกACI อย่างนี้นะคะทีนี้ยากลุ่มที่เป็น refractory cough ก็คือถ้าเราให้การรักษาแบบ upper lower ไปเสร็จแล้วยัง control ไม่ได้มันก็เป็นกลุ่มพวกneuromodulating agent นะคะซึ่งเมื่อกี้จริงใน PICO เนี่ยจะมียาทุกตัวเลยแต่ตัวเองยกตัวอย่างว่าอย่างโคเดอีนเนี่ยเขาเป็น weak recommendation แต่ว่ากาบาเพนทินจริงๆมีประโยชน์ตรงที่ว่าเปเปอร์มันเยอะใน refractory cough เนี่ยช่วยได้แต่ที่เราให้เป็น strength recommendation เป็น weak เพราะว่ามันมี side effect เพราะฉะนั้นเวลาเราให้ strength recommendation เราจะดู evidence base ที่เป็น RCT ก่อนแต่ว่าถ้าการรักษาตัวไหนมี side effect เราก็จะลดน้ำหนักลงนิดนึงกดคะแนนให้เป็น weak recommendation แต่ถ้าเราเจอคนไข้ที่เป็น refractory cough เยอะๆที่ทุกอย่างไม่ดีเนี่ยเราอาจจะ try กาบาเพนทินได้แต่โคเดอีนเนี่ยน้ำหนักมันน้อยให้เป็น case by case แต่โคเดอีนมันหาง่ายนะแต่อันนี้กรณี refractory cough ที่ไม่ใช่เป็นโรคต่างๆ common ที่เราพูดแล้วนะคะอันเนี้ย summary ของ recommendation นะคะในไทย cough guideline เขาบอกว่าให้ assess adjust reviewประเมิน cough score เสมอนะคะดูความรุนแรงดู VAS แล้วก็หลังจากนั้นเนี่ยเราก็ investigate ถ้าไม่มี red flag ไม่มีเฉพาะโรคแล้วก็ฟิล์มเชสปกติแล้วก็ต่อสไปโลฟีโนถ้าสไปโลฟีโนปกติตามอัลกอริทึมนะคะแล้วก็ทำบองเคียวชาเลนถ้าทำได้ซึ่งวันนี้ช่วงบ่ายเนี่ยจะมีเวิร์กช็อปทุกอย่างทั้งเป็นบองเคียวชาเลนทั้งส่องกล้องจมูกแล้วก็ทั้งเป็นสไปโลทั้งการพ่นยามีรู้สึก5เวิร์กช็อปเพราะนั้นเนี่ยการ investigation เนี่ยมีความสำคัญมากแล้วก็หลังจากนั้นเนี่ย initial ก็คือว่าหยุดบุหรี่เปลี่ยนยาสวิตช์พวกกลุ่ม ACE inhibitor ต่างๆแล้วก็อาจจะ consider short term ICS ถ้าทุกอย่างดูปกติแต่ถ้าทำฟีโนได้มันจะง่ายขึ้นในการไกด์ว่าควรจะให้รักษาหรือเปล่าหลังจากนั้นก็อาจจะให้แอนตี้ลิวโคไทอินได้ถ้าคิดถึง cough-variant asthma นะคะแล้วก็นอกจากนี้เนี่ยการรูทีนใช้โปรตอนปั๊มเนี่ยเขาบอกว่าโดยไม่มีอาการเนี่ยไม่ recommend แล้วก็โลโดสพวกกาบาเพนตินต้องใช้โลโดสนะคะตัวเองเคยทายกาบาเพนตินไปแล้วให้ไฮโดสคนไข้น็อกเลยหายไอแต่ว่าไม่ฟื้นเลย นะคะโลโดสก็จะช่วยได้นะคะในกลุ่มที่เป็น chronic refractory cough ก็คือไม่ response กับการรักษาเบื้องต้นแล้วนะคะเพราะฉะนั้นเนี่ยวันนี้ก็ขอจบ